Okay, so let's continue with the last part of this class. So what we're going to do now is look a little bit at some other specific type of images that we can make with MRI by emphasizing some things, and then also talk a little bit later on about the equipment and the safety. And the first thing that we can do is also, so I told you before, that by working with this principle that if we have motion of tissue between the types of gradients and pulses that we do, what actually happens is that we can selectively look at either moving particles or not. So if we do that, we can look at kind of fastly moving tissues, but we can actually also look at slowly changing tissues. And so since we're looking at water in the body, what we have is like we have not only the blood flow, but of course we also still have diffusion. So that means that you have very slow motion of protons, of water molecules within tissues. So, and we can actually now specifically also target these very slow velocities with very similar ways of looking at it. And so by looking at slow velocities, we can actually try to look at the effect of diffusion. And what we get then is we can try to measure locally differences in diffusion. So by doing different acquisitions, for example, what we can do is we can really look at where we have fast diffusion or in which direction we have differential diffusion. And that's one of the most interesting applications, because what we can do is, well, we can first, here is an application where we look at the amount of diffusion. So what we will see is that depending, for example, at some lesions, there might be lesions that still have the same water content. So on T2 or T1 would look very, very similar. It might be that they're actually structurally slightly different and would have like slightly different local diffusion. And so this is actually what you can do. So for example, in an acute stroke, so where you have like an hemorrhagic stroke, what we will see is that locally, the diffusion there has changed a little bit because we start to get thrombus or we start to get kind of coagulating blood. And so while the water content will be the same, what we will see is that it might be that the diffusion coefficient is different. And so that's actually another way to add like more kind of tissue kind of characterization to what we're looking at. What you very often see is that this type of images that look at diffusion or something specific, that they're even worse in resolution. So what you do is you want to compare this with the other one. So keep in mind, an MRI acquisition is always the whole combination of all these sequences. So you will always do like T2 weighted, T1 weighted, potentially proton density weighted, and then you might on top of that do some different images like either diffusion imaging or when we look at fast velocities, then we can look at flows or blood flow images in the larger vessels and things like that. So it's just compensatory. Now, as I said before, this diffusion can actually be anisotropic. For example, when we look at the brain, what you know is that neurons, so you have the neuron body and then you have the axons, and the axons are really fibers in a sheet. And sometimes also in other places in the body, we might have collagen sheets. So that means that when we look at the local diffusion, this diffusion is very specific in a certain direction, depending on the fibrous structure in that direction. So for example, in the direction of the axons inside, you will have a lot of diffusion, but perpendicular to it, you will not, because they cannot go out of the myelin sheets. So that means that if we would measure the diffusion in the different directions, we can actually measure a diffusion tensor. So all the different components of the diffusion vector. And we can study local anisotropy, which then we measure anisotropy in diffusion and we infer anisotropy in the local morphology. And this is actually what we do when we do, for example, tractography in the brain or diffusion tensor imaging in the brain. So what we do is locally in every voxel, we measure the dominant direction of diffusion. That would be the local fiber direction. And then, for example, we can do fiber tracking. So by following this kind of directions, you can say like, okay, we assume that within a fiber, we have a continuum of diffusion directions. And so this way, we can make these kind of tractograms, which show the direction of the fibers of the axons within the brain. And so you can look at connectivity of the brain. And so there are a lot of studies that say like the connectivity, the amount of connectivity, the distance of connectivity, and so on, they are related to different abnormalities of the brain, for example. So, and an application, so one application is of course in neurophysiology, where you try to understand it, but there's actually also applications in neurosurgery, for example, because here what you see is, so this is a patient that has a large lesion in the brain in this location. And so the question is now, you want to see is, okay, what will happen if I cut this out? So if I would do surgery and I remove this lesion, what will happen with the functioning of the brain? Will the function that is normally encoded in that part of the brain, will that be lost, or can I somehow spare it? And one of the things that you very often see is that lesions actually are not replacing the tissue, but are actually pushing away the tissue. So this will be a tumor, for example, that is growing, and that is actually pushing away the normal tissue. And so you see that fibers that normally would go through here are actually being pushed away. And so this way you can visualize before doing the surgery, saying like, okay, if I stay away there, if I cut it in such a way that I don't interrupt these kind of tracts, then I can probably save a certain function, certain motor function, visual function, or whatever. So this way you can actually get information on function of the brain or functional connectivity of the brain before you actually do some intervention. We can also look at perfusion of the brain, so really look at blood flow within the brain in general. So really the amount of flow besides the vessels, also by looking, for example, at dynamics of contrast, for example, gadolinium in this case. So that's not that important. But another thing that we can do also, and that's being, they call it like functional imaging, and which predominantly works for neurology, so functional imaging of the brain, is actually based on the use of contrast agents of the own body. And when you start looking at it, so within your blood, of course, you have your red blood cells, and we have the hemoglobin, which is binding the oxygen. And as you know, hemoglobin contains iron. Iron is one of the most important components of hemoglobin. And what actually is iron obviously has different magnetic properties than many of the other molecules. And so is in a way, as I said before, when you add metals, you can use it as a contrast agent. So iron is or can be used as a contrast agent. And what you actually see is that the properties, the magnetic properties of hemoglobin are actually changed when it's oxygenated or not. So oxyhemoglobin, when oxygen is bound, behaves slightly differently magnetically with deoxyhemoglobin when it kind of lost already or it gave away the oxygen to the tissue. And this is something that we can try to use, the different properties of these two. And actually the idea is that when we have certain neuronal activity, so we have a certain part of the brain which starts to function more, what happens is that it increases the oxygen extraction and it increases also the local perfusion. So it's actually changing very quickly the ratio of oxy versus desoxyhemoglobin. And by doing this before the activity and measuring it after the activity, we can see where locally there was a change in this ratio, thus inferring where locally there was more perfusion of blood being used and thus more neuronal activity. So that's what actually functional imaging of the brain is based on. And here you see, so this is actually called blood bold imaging, so it's blood oxygenation level dependent imaging. And so what you can do is you can measure the brain, for example, when you're not doing something, and then you do a task. The person here is moving the fingers, so it's using the motor cortex of the fingers. And then you see that there's a change in this MRI signal in the parts of the brain that are being used by, or that are being activated when we do this task. So you can think of a lot of tasks where you do that. And so what you do is you selectively, by doing a rest and a task stage, and then a lot of imaging and image analysis, because there's quite a lot of statistics and analysis comes to it, but you can highlight the regions of the brain that are specifically activated when doing a task. And so by choosing different tasks, we can actually decipher the regions of the brain that are working in this way. So again, these images are crap. You don't see anything on it. But what's more important is the difference between images. And so this way, by doing task rest, you look at the difference, then we can actually try to calculate some things. There's some very interesting experiments that have been done this way. For example, one was what I said, the motor cortex. But one of the things is also, can you use this, for example, as a lie detector? Because likely when you lie and you're telling the truth, you're actually using or activating different parts of your brain. And so here's an experiment that has looked at this. So where you say, like, you have to look at a certain card, say that this is the card that you have to remember. Then you ask some different questions, which are really questions, controls, and lies with rest in between. So you can say, for example, a control card is like, is this a known card? And then, do you have a test? Do you have this one? Yes or no, where you have to lie that you had it. You can do nothing, for example. And so by having these different kind of conditions, you can try to see if that activates different parts of the brain. And what you see there is actually you can prove that that's indeed the case. And so some people have said, like, look, this way we can really use MRI as a much better lie detector than the regular ones. But the thing is, of course, this is not at this moment being able to be used in court, for example, because the thing is, you need to do a lot of processing, and there's a lot of potential artifacts in order to get there and to do this in real practice. But the principle is there. So the principle is, indeed, we can look at differential activation of different parts of the brain, and these are different depending on different tasks or different way we use our brain. We will see that the local oxygenation will be different, and theoretically we can measure this with an MRI scanner. Practically is something else, but at least the theory is there. And so here again, what we can do is we can actually use this for surgery now. Just like I said before, it's like what you see here is, here you see some different lesions. So here what you see is, you see this like little gray darker zone. So this is a tumor, and actually here this is another patient with also a tumor there. And for example, when you let them do this kind of motor experiment, what you can say is like, okay, is this close to the motor cortex, or is this close to either the visual or the auditive cortex? And so when you do this activation and you measure, you see that in this patient, you see that this is very, very close. So if you want to cut away this lesion fully, you have a very large chance that you will actually damage the part of the brain that is doing this certain function. While in this patient, you see, like, look, we are reasonably far away, and it's unlikely that we damage some structures, or at least the structures that we want to specifically target to preserve that is happening. So this way, again, we can use this type of imaging in order to do fundamental research, so neurophysiology research, or we can use it in clinical practice to try to see, like, okay, if I do some certain therapy in a certain patient, am I looking at a certain region? Am I damaging something? Or should I change the planning of my surgery in order to spare it, or this kind of thing? So here we get additional information that we can get from this type of MRI scans. You can do interesting things with that research-wise. For example, what they did here is they put a bird in the MRI scanner. And what they actually did is they let them listen to the singing of themselves, singing of neighbors that they heard before, or singing of total strange birds that they have never heard before, and then try to look, for example, at are different regions being used for this. And actually, then you can see, or you can show that that's actually indeed the case. So this helps us in order to understand better neurophysiologically how parts of the brain are being used and how interpretations are being done, for example. Now, just like in the lab, as I told you before, you can use MRI for spectroscopy by the fact that actually every different molecule has a slightly different resonance frequency and so has a slightly different RF frequency that is being used in order to do it. We can actually also do this image-based. And so we can actually select certain voxels where we try to look, okay, what would be the chemical composition? So not only looking at water only and looking at the dynamics or the amount of water, but really trying to specifically target different metabolites. And so this way we can look, for example, at the composition of a tumor and try to say what type of tumor this is. Now, this is reasonably experimental. MRI spectroscopy imaging in a clinical setting is something which works in a research setting, but it takes a lot of time, a lot of processing, still with a lot of artifacts. So it's mainly something which is theoretically or for research interesting, but it's not very much used in clinical practice. Okay, now briefly a little bit about image quality and artifacts. So one of the things is that I told you before is the whole idea of MRI is trying to do measurements that highlight the contrast difference between T1 and T2. And so we do the timing of our echo time, repetition time, and ways of doing the measurements, depending on trying to discriminate these as best as possible. And so, of course, now, the longer we wait, or for example, also at some point when you do your repetition very, very fast, you don't let the T1 recover anymore. And so at some point, you have, for example, no signal. So you have a balance between the amount of signal and there's also the contrast between the different tissues and the speed of imaging. And so this way, we will see that every pulse sequence has a certain contrast that is determined on how long and when we are looking and where we make the kind of the balance between amount of pixels that we measure, so spatial resolution, the speed of the acquisition, and then the image quality contrast-wise, for example. Artifacts, there's a lot of artifacts. As we said before, there are magnetic field inhomogeneities that cause dephasing. We assume that we mostly look at stationary tissue unless we want to specifically look at moving tissue. So of course, when a patient is there, when the patient is moving, or even when the heart is beating, for example, we get motion that we don't want. So foreign particles or kind of implants, metal implants and so on, all of these cause artifacts, some of which we can compensate by doing longer imaging and doing this kind of T2 star compensation with this 180-degree flipping. And many of these really cause problems in location of the points and in the measurement of the points. And so these are, as an image that I already showed, you can either have signal loss or you can have artifact signals where signal is being measured at the wrong place. So where the phase encoding has changed. So if you have a dephasing because of an artifact, that of course would influence the phase encoding that we know. And so you can interpret wrongly, and that means that you can interpret the position wrongly, and you might see different points at different places. So you see sometimes like ghosting artifacts or something like that. Here you see some other ones. So here you also see some little artifacts that you see in this case because of different types of tissue, for example. But we're not going to go into much detail. Here's a typical one, a motion artifact, which is because of the heart motion. So because of the heart moves inside the chest, we get this kind of abnormal kind of artifacts. If we want to image the heart because of this motion, actually, when we don't take care of how to image it properly, and especially when to image it with our phase and frequency encoding, if we do not trigger on the ECG signal and measure at the right time and the same way, we get actually nonsense images. So while in CT also we need to do triggering on the ECG, in MRI it's even more important to do triggering in order to be able to reconstruct, for example, the heart. But one thing also keep in mind is like triggering always has to be done on the ECG. So we know because the ECG determines where we are in the cardiac cycle. But also keep in mind that at the moment that we put a person in the magnetic resonance scanner, which is actually a huge magnet, a magnet will actually change your ECG. And the magnet will actually even make it very difficult to measure the ECG. So if you would need to use metal electrodes, that will have this metal will cause artifacts, for example, or will cause heating at the moment that we use fast gradients and all this kind of things. So it is still quite tricky, but nowadays we can do actually quite decent triggering and we get quite nice images of the heart. What do these scanners look like? So here, this is the typical scanner. So this is a really standard scanner. So what we have is we have a tube and we have a long tunnel. This is one of the problems with MRI, is that because of the fact that the patient goes into a tunnel, so you really are locked into this tunnel for a while, a lot of patients actually have claustrophobia. And what you will see is that about 10% of patients are not able to go into an MRI scanner because they become claustrophobic and cannot stay still in there for a while. So for example, when you go into the scanner, what they give you is they give you something to press, like a button, or it's actually like a little kind of fluid or gas-filled pressure thing, so that whenever you're uncomfortable, you can actually push this button and then they come and get you out of it. Because when you get claustrophobic, otherwise it would become a problem. And you cannot come out of it yourself because it's a table sliding into there. And what you will see there is the way that it looks like. So in order to make this large magnetic field, what we need is we need a coil. So that's what I said, is we make magnetic fields traditionally by having a wire, which is kind of going as a coil, and we let an electrical current go through it, and that electrical current will induce a magnetic field. Now, I told you before, we are working with magnetic fields in the order of magnitude of 1 to 3 Tesla. So that's very, very strong magnetic fields. In order to make this magnetic field with a current through a wire, this is very problematic. If we would use a copper wire, either a very, very thick wire, we would need so much current in order to do it that this wire would immediately melt because of its resistance. So what we need is we need actually materials, coil materials, which have as little electrical resistance as possible so that we can get high currents through it. And for that, we actually use superconductors. So, you know, superconducting materials are materials that have virtually zero resistance for an electrical current. And we can add electrical current, and electrical currents are actually, because they're not attenuated by heat generation, they can go on almost forever. So these are great in order to make very high magnetic fields. But the problem is, of course, our current superconducting materials, they have to work at very low temperature. So mostly they are at liquid helium, or at least liquid nitrogen, but mostly liquid helium. So it's extremely cold that we have to cool this, because otherwise they lose their superconducting capability. But so imagine now, if you look at this scanner, what happens is that there is a copper coil or some other kind of metal. It's mostly some copper-like, or it's actually superconducting material, which is like some combination of. So you have these coils of superconducting material which are embedded in minus hundreds of degrees. So immediately close to you, so for example, 10 centimeters away from the patient, you have an extremely cold environment. So that, of course, makes it quite challenging also to make these things. And that also makes that in order to switch on or switch off the magnetic field in the scanner, that's not so easy, because what you need to do is you first need to cool down the coil to the right low temperature and then slowly add current. So it takes hours, for example, to build up this magnetic field. And so if there's a problem with the scanner, of course, at every scanner, there's like a button that you can press for an emergency. So the way they would do emergency stop would mean that you, for example, relieve all the liquid helium around it. And then, of course, immediately the current will stop because of heating. But there's a big chance that you damage the material. So also to stop a scanner is a very, very slow process. So that's why these are very tricky things. And so you have to be very careful with the safety of these magnets. And so what you will get is that because of this is like relatively expensive equipment, and an MRI scanner is much, much more expensive than a CT scanner, because you need all this technology and you need this cooling and superconducting material and things like that in order to make the magnetic fields that are strong enough. What you have is you have some alternative scanners. So here, for example, this is a scanner which is not a tunnel, but what you will see is that these are mostly much lower magnetic fields, and they might be based on these permanent magnets, but these permanent magnets are very, very expensive, for example. So, and you will never have as good images with these, but this is another way to do it, so depending on the application. Here you see some of the difference. So here's an open magnet, for example, and this is the normally closed magnet. And one of the things that you start to see here also is that what actually happens is we use the main coil in order to generate the magnetic field. But what we often do is we use very specific coils in order to do the measurements. Because as closer as possible that we can go to the body, the better our signal to noise ratio will be. And so what you will see is that based on this, you will have different coils, which I will show in a minute. One of the things that you also see is that most of the magnets, so when we look at these magnets, they are big, they are heavy, they have to be connected to cooling equipment. And additionally, especially because of the radio frequency fields that we're making and the fast switching gradients, what happens is actually also that the room that they're in, that we make this a cage of Faraday. So that means that we put metal wire in this room in order for the magnetic fields, the changing magnetic fields, which is the RF field and which are the gradients, that they don't go outside of the room. That makes it also even more expensive. And so sometimes they have found solutions for this. So there is currently a kind of very portable scanner being developed. So this is still under development. That is quite portable, but with, of course, much less resolution and possibilities. But what you will have is that in several countries, you actually get a full-blown scanner, so a high-resolution scanner, which is actually being put in a truck. And because this is also metal caging, it's very much caged. And so this way you can either go as displacement, or what you see is that also in some hospitals, actually this, because it can be expensive to build this room, what actually they do is they put the truck with the MRI scanner outside and they just make a tunnel to the hospital in order to do it. So this is one way to solve some of these problems. Mostly we use this to regular imaging and just to do diagnostic imaging. But what actually can do is you could use the scanner also to do surgery and interventions. There's a few places where they have, but this is not so easy, because first of all, the scanner is bulky and big. And also normally surgeons use metal equipment in order to do the surgery, even for cutting and things like that. And all of these things you cannot use. Plus also the RF that is being used for the imaging can generate artifacts in, for example, anesthetic equipment. So you have to make sure that all of these things are not doing artifacts. So that means that in reality, while theoretically it's possible, MRs are rarely used in an operating theater for live imaging. As I said before, there's different applications, there are different coils. So there can be a coil for looking at the head, there can be coils for looking a little bit more at body. And so really depending on which is the organ that I look at, I can use actually different measurement equipments in order to do this properly. So a normal scanner, so mostly you have an MRI scanner, comes in a room, you have the big tube, And then you have a whole range of coils depending on what you use this magnet for, so in clinical practice. Okay, last part is this safe? What's the logical effect? Well, in principle, it's relatively safe. So because we do not use ionizing radiation. So that means that MRI is very often seen as non-invasive imaging. But still, of course, we are working with some energies that could make differences. So first of all, we're using RF waves in order to do the flipping. And that RF waves will cause vibrations, and you will get also energy loss with your T1 relaxation. So it might be that you increase the temperature in the body. And so there's a maximal energy that you can use for the RF waves in order to do that. Similarly, with the gradients, as I told you before, when you have very fast switching gradients that can actually induce currents in the body and could be, for example, nerve stimulation. And so these are the things that can happen. The other thing, which is also for those that have had an MRI scanner, what happens is because we have these very fast switching gradients, what actually happens is that all the parts of the scanner start to vibrate in some ways. And actually, a scanner, an MR scanner, when these gradients are on, is extremely noisy when you're in there. So a patient needs to wear headphones, potentially with noise cancellation, in order to get this, because of all these very rapidly changing magnetic fields and the forces induced by this, actually these become extremely noisy environments in some ways. And that's sometimes a problem also for patients. The static magnetic field, as I said before, is very large and then potentially can give trouble, mainly with, for example, the ECG. So measuring the ECG can become a problem. What's also is that, of course, blood is flowing in this magnetic field. If blood contains ions or other charged particles and things like that, then obviously you have small currents that are being done. So that is a potential problem. But the biggest problem is actually with some other things, and that is that we are not able to bring metal objects in the scanner. Right? So that means that if we have a patient with a respirator, or if we have equipment like even like hairpins or jewelry or things like that, and especially if you have jewelry, like a loop of jewelry around your neck, for example, you could induce currents there that become so high that you really get kind of burning wounds or other wounds. Huh? So that is a big problem. Also, implants, especially metal implants, can become problematic. So especially in the older times, when they didn't look at compatibility of implants with MRIs, this was a problem. And a person that has an implant which is not MRI compatible can never undergo an MRI kind of acquisition. Similarly, if you have a pacemaker, for example, unless this pacemaker is specifically designed to be able to undergo an MRI examination, what can be is that you can wipe out the programming, for example, or you can even induce extra stimuli, which could lead to patient death. Huh? So what you now mostly have with modern pacemakers is that before a patient would go into the scanner, you put them in like a sleep mode. You can program this in an MRI mode, and then do a measurement and then reprogram them afterwards, for example. But that limits the application for patients that have this kind of implants. But the biggest safety, where most of the injuries and even deaths have happened with the MRI scanner, is by bringing foreign objects into the room of the scanner with such a large magnetic field. Right? As I told you, this 1 Tesla is the strongest magnets that you can buy, and you want to put in, that's what happens. And so here you see examples of where, for example, a cleaner brought in a cleaning machine, or even a worker brought in like a little trolley, or even a seat was rolled in for convenience. And you see that these are really, as a projectile, immediately being attracted by this enormous magnet. So this is a large problem, first of all, because of the safety. This goes in at very high speed. If there's a patient in there, you really get injuries. Secondly, you will definitely damage the scanner because of the impact. And thirdly, you need, as I told you before, it can take days in order to power down and power up a magnet safely. So you will really lose this amount of time in order to do patient, that you cannot do patient imaging, and so this can become very expensive. And here you see even other examples. So this is a real example of where somebody came in with scissors, and you have scissors like being kind of thrown in and then causes injury. You cannot bring a patient in a bed unless the bed is MRI compatible. So some people sometimes forget that also. Or things like oxygen tanks, they can become really like big bombs and be very, very unsafe. So this is actually the biggest safety problem. So that's why you see in an MRI scanner room, you always see at the doors, you see all these things. Be careful what you bring in. And also patients, they have to like fully undress, take all the jewelry off before they can go into the scanner. And also the operators and the doctors that go into the scanner, you have to be sure you cannot keep your wallet, for example, in your pocket, because your bank cards, for example, the magnetic information and the chips in your bank cards will be totally wiped. And if you have coins which would contain metal, actually they would actually or could be attracted also by the scanner. So these are some of the biggest safety problems that you could have with the scanner. But in general, as a conclusion, MRI is a very versatile scanner. You can really look at a lot of different things. You can look at anatomy in different ways. You can do tissue characterization. You can do, in principle, at blood flow. You could look at things like, as I said before, dysfunctional imaging and so on. With the disadvantages that, first of all, it's a very expensive scanner. It's the most expensive scanner that we have. Patients might not be able to go in because of claustrophobia. Anything metal and implant you cannot use. And some of the things is we mainly look at hydrogen, so we cannot look at bone, for example. And also when we look at the images, the spatial resolution is actually, it's not as bad as nuclear medicine, which is orders of centimeters, but actually we can only do orders of millimeters. And with other imaging modalities, we can actually sometimes go better. So it's always a balance again. It's like, what do we want to look at? Do we need this tissue contrast? Do we need this complexity of scanning in order to look at that? Okay. You still have a question? Because I'm finished.
Yes, I wanted to ask you a question. But do you think, in your experience, that there can be like a kind of threshold in order to evaluate like the risk versus the advantages when, for example, a patient has a specific type of implant, and you know that this implant is going to generate some kind of artifact because you have previous experience, like in your personal view? Like what is like
the thing is that in general, you really avoid putting patients with implants in the MRI scanner.
Yeah.
But for example, if you have a young person that regularly needs to undergo imaging, then you don't want to use a CT scanner because then the radiation damage or radiation problem can be more. But mostly adult, especially older patients with implants, what you mostly would do is, okay, we go for a CT instead of for an MRI. But sometimes, I mean, it really depends again on what's the information that, is it crucial to make a diagnosis or decision making, yes or no, and then you would take the risk, yes or no. But in general, radiologists try to avoid to get patients with implants or things like that into the scanner.
And in this, there are included, for example, very like small dental implants, for example, instead of.
Dental implants are rarely a problem unless you need to do imaging around the teeth. So mostly they will cause artifacts. They will rarely cause really problems with danger problems, because mostly also the metals that they're made of are mostly not too influenced by the scanner.
Okay, so it is not like a safety concern, but more like a kind of effective concern when obtaining the information on the image.
Yes, it will cause artifacts. It will for sure cause artifacts. So the more implants you have, the more artifacts around that part. So sometimes you cannot see it, but there's very few implants that would cause problems with the scanning. Okay. Because a lot of implants are also based on titanium, for example, and titanium doesn't cause problems. Yeah, it doesn't cause safety problems indeed.
Okay.
Yeah.
Thank you very much.
Other question?
Yes, you said that MRI machines like take a long time to activate and deactivate. So on a daily basis, the hospitals, they let the machines activated or not?
Yes, yes. It stays on for months, if not years. You try to avoid, it's only for maintenance. So of course, while you install it, and then when you have to do major maintenance, or when there's a safety problem, that you would switch it off. And otherwise, you would always leave it on. So day and night, 24 hours, the main magnetic field stays on.
Okay, okay, thank you.
Any other questions? Okay, then that was it. So next class, we will look more at an application. So we now covered all the imaging modalities, and next class, we will talk about cardiovascular applications. So how we can use imaging to study specific organs in more depth. Okay, thank you very much.